welcome all the fellowship applicants. I'm Seth, I'm one of the adult ID fellows, and I just go through these slides here. No disclosures. So the title of my talk is Mimickers. We have a 46-year-old male with a history of right atrial pseudoaneurysm rupture that underwent repair and had pericarditis with a pericardial effusion, who's now presenting with recurrent chest pain and headache. So 2 months prior to this admission, this patient was hospitalized with chest pain and low-grade fevers. He was found to have a pseudoaneurysm protruding from the right atrium and pericarditis and underwent bovine patch repair. OR cultures of the pseudoaneurysm were negative. Cytopathology of the pericardial fluid showed some mixed inflammatory cells with numerous eosinophils, reactive mesothelial cells, histiocytes, and lymphocytes. He was discharged after this repair and hospitalization with ID and rheumatology follow-up for further workup of what could have been causing this. He was being worked up in the outpatient setting, then he went to Israel 10 days ago. And while he was there, developed some word-finding difficulty and was noticed by his wife to have an unsteady gait. He's returning from this trip now with worsening left-sided chest pain, headache, and nausea. In terms of his past medical history, he had this atrial pseudoaneurysm, also had a hernia repair in the past. These are the medications that he's on, no allergies. He lives in Maryland. His occupation is he sells furniture and he travels a lot for this. He's traveled to Malaysia, China, and Vietnam in the last 2 years to visit factories. He's been both in rural and urban settings. He traveled to Cancun 6 months ago for vacation. He keeps a pretty strict kosher diet. He has a prior smoking history. He enjoys fishing, catch and release only. He has a pet dog. His brother owns some exotic birds and a pet lizard. And his daughter likes to ride horses. He is monogamous with his wife. When we see him, his vitals are within normal limits. He's afebrile, standing while in room air. He's just very uncomfortable appearing, very nauseous, kind of in the process of maybe having some emesis. His conjunctiva are clear, his heart sounds normal, lungs sound normal, abdomen is fairly benign. His neuroexam, there's nothing focal on his neuroexam, rashes. In terms of his labs are fairly unremarkable. He doesn't have a leukocytosis, he's a little bit anemic. He does have a slight elevation in his percent of eosinophils on his diff, and then his BMP is fairly unremarkable. His imaging though, so he undergoes a CT, chest, abdomen, and pelvis with contrast, and now there are multiple bilateral solid pulmonary nodules with surrounding halo. These are new from 2 months ago when he was seen. He has a prominent subcentimeter left cardiophrenic angle lymph node and a prominent right hilar node, and he has numerous soft tissue masses in the pericardium, and then scattered subcentimeter sclerotic osseous foci in the left femur and in the bilateral iliac bones. He's also found to have multiple enhancing lesions in the temporal lobe, left anterior thalamus, right parietal lobe with parenchymal hemorrhage and surrounding vasogenic edema. The lesions shown here. So we have a 46-year-old male with a history of right atrial pseudoaneurysm, underwent rupture and repair, pericarditis, pericardial effusion, who's presenting with recurrent chest pain, found to have new pulmonary nodules and cerebral lesions. I appreciate help with the differential diagnosis.
Right.
I'll stop sharing.
Interesting situation here in a person that seems to be relatively healthy. And over what time frame were these symptoms again? I mean, 2 months ago he had the surgery.
2 months ago he had the surgery.
And he felt he recuperated, or
yeah,
not?
he had some like low-grade fevers after that, then had recovered, traveled to Israel, had the word-finding difficulty and the gait imbalance, then returned, and then just a few days ago developed this acute onset nausea and chest pain.
Yeah. So interesting, and I'd say a fairly complicated case potentially, but oh, Manak Shaw left the room. Okay, all right. So okay, I'm going to move on from there a little bit. Let's see here. Eileen Scully, are you available to give us some initial thoughts on this interesting presentation? Seems unlikely.
Sorry about that. Sure.
Oh, great. Thank you.
Had trouble unmuting, as we all say. So this is a 46-year-old with an extensive travel history and a prior unclear etiology pseudoaneurysm, which had some inflammatory features for which it sounds like there was an open infectious versus inflammatory differential, who's now representing with progression that we could either link or split, but seems likely related to the initial pathology with sort of multifocal involvement with both CNS disease and pulmonary nodules. And also, Seth, you did say there was multiple pericardial soft tissue lesions as well, is that correct?
Yeah, he has some masses in his pericardium as well, and then some sclerotic foci in his femur and his iliac bones.
Okay, so widely disseminated process. So I'm going to just be upfront that I have absolutely zero idea what this is, but I will try to formulate some possibilities so that we can do some diagnostics and then other people can chime in. I think just starting at the beginning, it seems unusual for a standard bacterial process based on the lack of initial purulence or other features, and then the tempo of the illness with the delay between the initial repair and then progression. I think some unusual, more standard bacterial types of organisms that have more indolent courses like nocardia, you can probably not avoid saying with a pulmonary and CNS presentation. It could also be a more occult bacterial infection with brain abscesses from embolization and pulmonary abscesses from the same. So I would put standard bacterial causes there, maybe, I don't know, something with the lower virulence like enterococci or one of the nutritionally deficient strep species. But, and I suppose you always have to say just standard staph and strep, although this just seems very unlikely. I think much more plausible seems to be something like an atypical process, on which I would include mycobacterial infection. Again, with the multi-system involvement, relatively occult to diagnosis kind of a process. Although I don't think of that as being associated with pseudoaneurysms, although I wish Manon was here to correct me on that. As also, I don't know, and maybe Elise is here, is if there's a particular NTM that has a vascular predilection. So then other less common bacterial processes would be like the Burkholderia melioidosis type of presentation with his travel to Southeast Asia and other locations where that's endemic. And then another atypical bacterial associated with vascular presentation would be syphilis, although having a really hard time imagining how that's related to the CNS and lung lesions. Moving on from that, fungal pathogens, I think coccidiomycosis is occasionally associated with pericarditis. It sounds like he's got sort of plenty of travel such that histoplasmosis and other things, he's probably been in endemic areas. Cryptococcus certainly can cause cryptococcomas and CNS presentations. With this degree of dissemination in an immunocompromised host, it seems unlikely, but I'll leave it up there. And then I have no idea if blastomycosis could do this, but I guess I will just add it to the list. Other processes like parasitic infections or things of that nature, I am having a hard time coming up with one that would fit that. I mean, in my patients, I always think of toxoplasmosis, which can cause both pulmonary and CNS processes, but I just can't necessarily put that together here. I'm sure there are other things I'm leaving out there, but I'll leave that for someone else to fill in. And then viral etiologies, I'm going to leave that one blank because I just can't put one together, but maybe someone else can. So I think because I'm just flailing in the dark, I'll stop and let someone join me.
Eileen, thank you. It is truly a strange case, and thanks for starting off with some really important considerations. Anyone from the audience? I was sort of wondering, so there was bone, there was pericardial, there was brain, and how many brain lesions? Were there?
At least 3.
Yeah. And with the bone, I mean, I was kind of thinking of some of the histiocytosis syndromes, which are usually more in kids. What's that?
Dave just put the same in.
Yeah, and there's all sorts of names here. Langerhans and Hans Sugarschweiler or something that I've since forgotten. But the whole range of those kind of macrophage syndromes. And I was also just wondering about an immunodeficiency state that would allow for something like an NTM to have dissemination. We've seen anti-IL-12 antibodies, gamma interferon defects, and so on. So some kind of anti-IL-12 or gamma defect that might somehow lead to a predilection on that a bit. But is his background, is he Ashkenazi, do you know, or?
I don't know that.
FMF can cause serositis. You can get some tissue and odd presentation. So I was just wondering a little bit about that. Psittacosis, is that what?
Yeah, so we can add a couple. So Matthew Campbell has added the Kynococcus. Dave, IgG4.
Yeah.
This would go under NTM, but Bill's just doing specifically on Chimera, I guess it's the cardiovascular surgery.
Yeah.
Mark psittacosis.
Psittacosis. There's an IgG4.
Yeah.
Disease.
And then
Like a pseudotumor kind of
yeah,
thing.
so he's adding actino
Okay.
and aspergillus. And then Ethel is going to add Salmonella pseudomonas.
Mm.
Lull.
Well, Seth, how are we doing up here?
It's not up there.
Not up there. Well,
This is a tricky case.
yes.
We add Brucella.
Brucella, okay. Okay, I'm sorry, yes.
I was saying the same thing for Celeste.
Brucellosis. Okay. All right. Okay, it sounds like the well is dry. Is it up there now? Still not up there. All right.
This is our
Seth.
first stump of the academic
This
year.
is, you stumped the chumps,
Right?
all of us.
You got
So, but thanks, this was a tough one for sure. I
Bill
assume.
is saying rhodococcus, but I'm just going to say I also know that that's not.
Okay, I think this is where tissue is the issue, right? But highly interesting presentation.
Yeah.
Thank you, Eileen, for taking us through this.
And
For being the first chump.
No, we're all chumps.
Yeah, we were all
every one
very
of us.
perplexed by this, and
Yeah.
there were a lot of teams involved. So in terms of infectious workup, so he underwent a BAL with lung biopsy. The lung biopsy just showed alveolated lung parenchyma with focal organizing pneumonia. Bacterial, fungal, and AFB cultures had no growth. They did a gene expert that was negative. Also did an OMP on his BAL, which was negative. CSF was clear. There were no white blood cells. The glucose and the protein were unremarkable. And the CSF work was negative as well. The crypto, bacterial, fungal, AFB, VDRL, HH36, JC, virus, VZV, HSV, they were all negative. In terms of his blood and serology workup, negative T-spot, his fungal markers were all negative. Checked a lot of different things like Q fever, toxostrongy, HIV, Bartonella, blasto, cocci, histo, brucella. And then we even sent out a Carius next generation sequencing on him, which was negative as well. So he underwent IR biopsy of one of the pericardial lymph nodes. He was found to have angiosarcoma. So thinking about this case, and there was a lot of, it had been seen in the outpatient setting by ID, there had been a lot of ID involvement. I think there was a lot of push for ID to come up with a unifying differential diagnosis. But thinking about this case, like one of the things that I wanted to kind of learn from this and think more about are what infections are mimickers of malignancy, and then what malignancy can mimic infection. So in terms of thinking about mimickers, I think this is just funny. If you PubMed search the great mimicker, there's over 2,000 articles ranging from people talking about malignancy to COVID-19 to the EKG being the great mimicker. So I think it's just funny that we use this terminology a lot. That's very non-specific. But in terms of the great infectious mimickers, I broke this down, kind of looking through the literature and doing literature review to see what organisms most commonly are mimickers for malignancy. And so these ones I'm going to call the great infectious mimickers. I think mycobacteria being at the top of this list, really suspicious for, findings that can look like metastatic disease, pulmonary malignancy. For example, there was a cohort study out of Japan where there were 16 out of 460 patients who were initially diagnosed with pulmonary malignancy who later were diagnosed with mycobacterium and BAL. Fungal infections, I think we all have a lot of respect for in terms of looking like a metastatic disease as well. This was an interesting cohort study out of Stanford where they had 12 patients who had invasive molds who actually were initially diagnosed with non-small cell lung cancer. Fungal infections being involved. Syphilis, I think it was Osler who called syphilis the great imitator. And I think it's something we think less about now, but I think can look like a lot of different types of malignancies, ranging from rectal cancer to cutaneous malignancy or metastatic disease. This is a citation of an interesting case report where secondary syphilis mimicked a lymphoproliferative disorder or lymphoma. The PET scan from that is really remarkable, and it looks like the patient has lymphoma that actually had secondary syphilis. Brucellosis, we'll talk a little bit about. I think it was interesting in this case, for me, at least with the travel to Israel and then CNS manifestations, bone manifestations, and looking like potentially pericardial involvement in metastatic disease. There's an interesting case report of a patient from Peru who had neurobrucellosis that mimicked a CNS tumor that was initially misdiagnosed. And then Burkholderia or amyloidosis was something that we had talked about on the differential. Also, depending on exposure, so something that can look like metastatic disease, or in that case report, bronchogenic carcinoma. For brucellosis, I thought this was interesting. It was something that was on my differential when I saw him, given the bony lesions, the neurologic lesions, and the pericardial involvement in the travel to Israel. There have been outbreaks of brucellosis in Israel. This was something that I was working on with Peter Rabinowitz at the University of Washington in the Center for One Health there. So there have been some outbreaks of brucellosis there. And then this interesting case report of neurobrucellosis that I was mentioning as well. But this patient had a really strict kosher diet, and his brucellosis serology was unremarkable. Then the lesser known mimics, I'm going to call these, I think are ones that are also important to think about, but don't come up in the literature quite as often. Bartonella being on this list, mimicking different solid tumors like breast cancer, lymphoma, and sarcoma. There's an interesting cohort study that I'll talk a little bit about, where there were 11 cases at MD Anderson that initially had all been diagnosed as cancer, but then came back and they were actually Bartonella. Helminth infections, also can look like metastatic disease. I was really interested in this patient about paragonamyosis, given his travel to Southeast Asia. There's an interesting case report of pulmonary paragonamyosis mimicking a metastatic pulmonary tumor, as well as mimicking angiosarcoma. And so with his cardiac, pulmonary, and CNS involvement, I thought that paragonamyosis was interesting, and we had the OMP on the BAL that was negative. Nocardia and actinomyces, which was also on the differential. Again, things that can be kind of indolent and mimic metastatic disease. And this is an interesting case report about 3 cases of pulmonary nocardia with cerebral abscesses that mimic lung cancer. So in terms of Bartonella, I think the history of this is interesting. Bartonella I have a particular fondness for. Was the first organism that I studied at Stanford with Stan Falco and Lucy Tompkins, and they share with me kind of their discovery of Bartonella as the agent for bacillary angiomatosis. So we know Bartonella cell can cause a granulomatous lymphadenitis, so cat scratch disease, or the vascular proliferation bacillary angiomatosis that we see in immunocompromised patients. Initially, they thought maybe it was a rickettsial organism. This was kind of, in the early days of DNA and sequencing, things like that, that they were then able to identify it as Bartonella henselae as a bacteria. But it can mimic lots of different malignancies. And this is this interesting case, kind of short study, cohort study from MD Anderson, where they looked at 11 cases who had initially been diagnosed with malignancy, who actually had cat scratch disease. It was interesting to kind of look at the demographics and exposures to cats in this cohort. And in part of this study, there's a literature review. They look at 36 other cases where cat scratch disease mimicked malignancy. And the kind of overall similarities between these cases is that a lot of them mimics lymphoma as well as solid tumors, including breast, sarcoma, and skin cancer. So it's kind of an interesting study to look at in open form infectious disease. And then given this case, I was also curious about what infections does angiosarcoma mimic. I think it was something that it was unexpected, and I think important to think about going forward as we try to expand our differential. So angiosarcoma can mimic lots of different infections. There's an interesting case report of angiosarcoma mimicking an infected aneurysm and pseudoaneurysm in the abdominal aorta. Angiosarcoma mimicking cellulitis, so people who initially were diagnosed with cellulitis of the scalp and facial cellulitis actually ended up having cutaneous angiosarcoma. Angiosarcoma mimicking pericarditis, kind of like in our patient. They had a primary right atrium angiosarcoma, similar to this patient, mimicking pericarditis. And then an interesting case report of angiosarcoma mimicking syphilis. This was penile angiosarcoma that was initially misdiagnosed as syphilis. So I think just interesting things to keep in mind going forward, thinking about our differential. So key points from this case, I think we could think about one of the great infectious disease mimickers and malignancy. I think mycobacteria, fungal infection, syphilis, brucella, and Burkholderia, my review would be the ones I would put on here. The lesser known mimickers, I would include Bartonella, helminth infections, and Nocardia and actinomyces. And I think one of the big learning points from this case, I think there were some delays in diagnosis and treatment, because I think this was initially had been kind of misdiagnosed as an unknown infection or rheumatologic sort of disease, which led to delay in ultimate diagnosis and treatment. And then angiosarcoma can mimic multiple different infectious diseases. These are the references here.
Great. That was a nice overview. I think Charlotte just made a comment.
Just saying, just noting LGB can mimic rectal cancer and with HIV as an example of bacteria mimicking malignancy.
Yeah, so Seth, I mean, given the findings, often the radiologists help. Was there clinical correlation suggested, or were some of the nodules more suggested malignancy, or they're like could be infectious, could be malignancy?
Yeah, it's more of it can be infectious and malignancy. And it was really a lot of coordination with interventional radiology. There's a great interventional radiologist who we were able to get who sampled that node, and there was really, it was actually really remarkable. We were talking like late into the night, so we got the path back, and he was talking that the diagnosis was made, but it took some
And
time.
they don't know where the primary is, so
They suspect cardiac.
so his prognosis is not very good,
Yeah.
unfortunately. Yeah. Any questions? Did he get empiric antibiotics during this, or was
No,
that
he
held
didn't.
off?
Yeah, that was held off as diagnostic workup was.
Yeah. Was he on the medicine service? Or?
He was on.
Janeway.
Yeah. he was
Yes,
on
the
that.
That's how I
Giants.
knew.
Okay.
Like, what is it?
Right. What did Kelly?
Really just saying huge shout out to the team who obtained the specimens, made sure that they all went to the labs appropriately. Amazing team effort.
Yeah. Often in these complex cases, it really is good communication and coordination is important. We've filed a number of things when things, you've asked for things, but they don't get sent. And of course, it's a surgical sample, so go back is a big deal. So it's good to have that all on board ahead of time. Any other comments? And I think your points about looking at it from both ways are really important. I think, at least for outpatient, what we get seen the most is the lung. And where, lung tumors in smokers are removed because of a positive PET scan turns out to be MAI or something of that nature. And that's probably the #1 mimicker. Actinomycosis is pretty rare. Then all the others, I think, as you said, are more in the case report territory. So
Hi, Seth, this is Eileen. Thanks for that case and also for, I think one of the things most of us love so much about ID is that we always stay, even if it doesn't look like it's our problem. I wonder about the use of PET in these cases, not just to look for avidity, but to look for intensity. And I know that in some case settings that is useful with like known malignancies, but I don't know how good we're getting at differentiating whether something looks like an indolent infection versus an aggressive malignancy, just because these syndromes are so hard. And here, obviously, there was some accessible tissue and that really helped. But in cases where there's not, I do still think we need tools to try and sort out infection versus things like malignancy.
Good point.
Great. Well, thanks, Eileen. That's a great point. Any other comments?
I guess the biggest yes is happy that no one here got it either.
Well, angiosarcomas are a notoriously difficult tumor because they will not, I mean, a lot of times they'll have regional spread in a limb, but if they're occurring elsewhere, it can be very difficult to diagnose. And I guess in retrospect, the thought was somehow that process was part of the pseudoaneurysm, but just wasn't pathologically identified. Yeah,
And it was rapidly progressive.
right. Yeah, unfortunately, some of them are. The treatment's really terrible and it's usually radiation.
Yeah, that's what he's scheduled for.
Yeah. Okay, well, thanks very much. Look forward to meeting a few of our interviewees today. I hope you have a great day here virtually in Baltimore and at Johns Hopkins. And thank you all for coming in person. So until next Tuesday.